We have always heard that cancer requires a multidisciplinary team approach. So why is it so, and why is it always a multidisciplinary team approach?
Breast cancer. Most of the patients would undergo a surgery, and many of these patients would require chemotherapy. Almost more than 50% of these patients would also require radiation. But one very important aspect of today's cancer treatment, especially for breast cancer, is the sequencing of treatment. The patient should receive chemo first or surgery first, and that is a thoughtful process. But gone are the days when vocal cord cancers were treated by surgical removal of vocal cord or larynx cancer were treated by surgical removal of the larynx.
पेशेंट को डर रहता है कि मुझे रेडिएशन मिल रहा है, दैट मीन्स आई एम द रेडियोएक्टिव पर्सन. तो फैमिली में जो भी है, बच्चा है, एल्डरली है, कोई भी रहता है, सो दे विल गेट एक्सपोज्ड बिकॉज ऑफ हिम. सो ऐसा नहीं है.
Hello and welcome to Sahyadri Health Talks. I am Dr. Tushar and today we are going to talk about advancements in the treatment modalities of oncology. Yes, the word cancer. The word cancer is strong enough to send chills down the spine, let alone be the thought of fighting it. But just how cancer is never fought alone, it is never treated with a single specialty. We need a panel of doctors, and that's what makes today's podcast extremely special. Because today we have with us the entire panel of Oncology team, Sahyadri Hospital, Deccan Gymkhana. So let's get started without any further ado. Let me introduce Dr. Jagdish Shejul, the radiation oncologist.
Hello.
Dr. Vinod Gore, sir,
Hello.
surgical oncologist, and Dr. Tushar Patil, sir, the medical oncologist.
Good evening.
Welcome on board, doctors.
Thank you.
How are you, and how does it feel to be on the podcast today?
Yeah, absolutely fine.
Absolutely. Feels nice.
So we will start with something very basic, sir. We have always heard that cancer requires a multidisciplinary team approach. So why is it so, and why is it always a multidisciplinary team approach? Why it cannot be treated by a single doctor? Dr. Tushar Patil, what
I'll
are
give you
your
the
thoughts?
commonest example, breast cancer. Most of the patients would undergo a surgery, and many of these patients would require chemotherapy. Almost more than 50% of these patients would also require radiation.
Achha.
So then these patients go through surgery, chemo and radiation, all the three modalities. One more very important aspect of today's cancer treatment, especially for breast cancer, is the sequencing of treatment. The patient should receive chemo first or surgery first, and that is a thoughtful process. Once all the reports coming, including the PET scan and the biopsy reports, we all sit together and formulate a treatment plan so that the sequence of treatment can be decided and the patient's treatment can be given the right justice.
Okay.
And second thing is, this is more convenient for patient also, because many times surgical oncologist sees patient separately, then medical oncologist sees patient separately, then radiation oncologist sees patient, then some discussion happens. So patient keeps on running to all the doctors. So rather than that, it is better that this panel discuss with each other. They see the patient at the same time, and after the discussing with each other, they decide on the sequencing of the treatment. यदि ऐसा करते हैं, एक साथ ट्रीटमेंट का डिसीजन लेते हैं, जो भी डाउट्स है पेशेंट के मन में या किसी दूसरी मोडालिटी के डॉक्टर्स के मन में, वो वही के वही क्लियर हो जाते हैं, एंड पेशेंट विल रिसीव अ गुड प्रोटोकॉल फॉर द ट्रीटमेंट. And definitely there is no bias, because one person is not taking the decision. Whole panel is taking decision. So the personal bias is also neglected and get nullified. And as per the protocols of every specialty, we tailor the treatment of the patient, and patient receives the best treatment.
So likewise in this scenario, cancer treatment के बारे में, so cancer is not one point treatment.
Achha.
So it is the course of treatment, and different modalities are going to play different roles. किसी कैंसर में surgery is the primary treatment, so उसमें chemo and radiation are helping to the surgery.
So are we saying कि not all cancers might require chemotherapy, or not all cancers require
Correct.
radiation?
Yes. Correct.
Okay.
So today's era is of precision oncology. That is it's a targeted approach to cancer.
Okay.
A patient-
Yes, actually my next question was on that.
Patient-
We have heard so much about precision oncology.
Correct. every patient would not require surgery, every patient would not require radiation, every patient would not require chemotherapy. Gone are the days when vocal cord cancers were treated by surgical removal of vocal cord, or larynx cancer were treated by surgical removal of the larynx.
Yes.
Today with chemo radiation only, most of these larynx cancer patients can be completely cured. So then is the role of all the faculties sitting together and deciding the treatment which is the best for this treatment and eliminating all the biases.
So precision oncology is kind of think the person-centric treatment.
Okay.
It is not like someone had some particular cancer and we have the guidelines. If the cancer is this much and at this stage, this should be the treatment approach. But
So
now that
basically,
era has been gone.
this kind of helps you out in charting out the treatment plan.
Yes.
It's a tailored
It's a tailored treatment for that particular
Personalized treatment, that is
Because-
precision oncology, with the advancement in artificial intelligence, data science, and the different advancement in molecular things
Acha.
is all included in the precision oncology.
The same kind of cancer, same kind of stage, 3 different patients may have 3 different profiles. The tumor profile can be different, the patient profile including the comorbidities could be different, and sometimes even the patient preferences could be different. So there are patients for a rectum cancer who would say remove the tumor, sir, a stoma is okay for me. There are some kind of patients who would say, sir, no point of time I will be ready for a stoma, please try to make sure that my continence is preserved. So many preferences from patients, so many preferences from doctors, and all this taken together into account form the treatment plan.
So, sir, as we talk about the advancements of treatment modalities in oncology, radiation oncology has been booming. So, what do you have to talk about it, and what do you have to say about when I ask you how was radiation oncology in past, and what are the recent developments that has happened in radiation oncology?
So about the past thing, so radiation पहले हम लोग कोबाल्ट मशीन पे देते थे. It is simple, pretty much simple machine, radioactive source के through ये कोबाल्ट source के through देते थे. Now we have come to the LINAC, linear accelerator. So LINAC we have C-arm base and a ring base LINAC type. So ring base में the topmost model is the tomotherapy.
Acha.
That is what we have got over at Hadapsar Sahyadri Hospital.
Okay.
And in C-arm type LINAC, we have got the topmost variant currently in scenario, that is the variant with true beam with HyperArc. That is
Okay.
what we have got at Deccan Sahyadri Hospital.
Acha.
So nowadays the shift is from the basic cobalt to the newer advances in radiation oncology. We can say the LINAC has been passed so many phases. Now it has moved to the more and more precision.
So, linear is the recent advancements.
LINAC is there,
Acha.
but their subtypes are getting evolved very fast.
Okay. So, sir, correct me if I'm wrong here. But what I have understood is whenever somebody, is diagnosed with cancer, typically, most of the times they go to a medical oncologist, which is your profile, Tushar Patil, sir. So, most of these patients, when they come to you, they might say that, radiation is scary. And, when they need one. They might say that the radiation is scary and how is the technology, so how do you convince these patients and how do you explain it to them that how technology has changed when it comes to radiation oncology as a medical oncologist?
So first thing when I tell the patient is that what is your treatment plan? Surgery, chemo and radiation. Then patient would ask me about every side effect of every treatment. For surgery, I would tell them it's advanced to a certain extent that your morbidities will be taken care of, your stay would be the minimum, and of course the surgical oncologist Dr. Vinod Gore is the best person to explain you about what is going to happen with you. For medical concerns, I would be the right person to approach. Similarly for radiation, when they asked me questions like side effects of radiation, is it scary? I would try to soothe them out by telling that the modern day radiation treatments are with minimum side effects and great precision, but Dr. Jagdish is the right person to handle this and answer all your queries.
Okay.
Yeah, any patient actually, initial days when cancer treatment started, you can say 25 साल पहले जब कैंसर के बारे में बात करते थे तो पेशेंट के मन में सबसे पहले अभी भी क्या होता है, कैंसर से ज्यादा लोग कैंसर के साइड इफेक्ट को देखते हैं. केमोथेरेपी के साइड इफेक्ट है, सर्जरी मॉर्बिड है, रेडिएशन के साइड इफेक्ट है, रेडिएशन देंगे तो पूरा जल जाएगा एंड दैट विल बी फॉर लाइफ, एंड केमोथेरेपी के बहुत सारे साइड इफेक्ट होते हैं, बाल जाते हैं, इन्फेक्शन होता है, ये सब जो बातें हैं वो सबसे पहले उनके मन में ये बातें आती है. अभी नाउ the patient has to understand and we have to explain them properly that now with the newer modalities and research and newer techniques, these side effects are easily managed and side effects are less. Treatment is getting more and more specific, more targeted. So initially it was like a carpet bombing.
Carpet bombing.
So
yes.
कीमोथेरेपी देना है तो उसके आजू बाजू के ट्यूमर के आजू बाजू के सब सेल मर जाते थे.
अच्छा.
अभी पर्टिकुलरली वही कैंसर सेल को मारने वाले ड्रग्स.
So, sir, what I understand here is you are talking about the targeted therapies,
Yeah.
right? But is it actually possible कि targeted therapies में is it that precise and accurate कि हम सिर्फ cancer cells को ही target करते हैं and without damaging the surrounding?
In majority of cancers, yes.
अच्छा.
बहुत सारे कैंसर है जिसमें हम टारगेटेड थेरेपीज यूज करके उसी कैंसर को मारते हैं. बेस्ट एग्जांपल इज थायराइड कैंसर. थायराइड कैंसर में जो आयोडीन है वो सिर्फ थायराइड की पेशी लेती है. तो उसका एब्सॉर्प्शन थायराइड की बेसी करती है. तो थायराइड कैंसर में हम आयोडीन को एक मॉलिक्यूल अटैच करते हैं रेडिएशन का, जिसको रेडियाडिन बोलते हैं 131. तो इफ दैट रेडियाडिन इज गिवन टू द पेशेंट, दैट आयोडीन will be absorbed only by the cancer cells or thyroid cells.
Achha.
So it will kill only the cancer cells of thyroid,
So it doesn't
and normal cells will not be damaged.
cells, okay.
So there is almost negligible damage to the surrounding tissue.
Achha.
Same is true in many targeted chemotherapy drugs. Same is true in many newer modalities like radiation. Radiation के जो भी अभी नए ट्रीटमेंट्स या नए मशीन्स आ रहे हैं, उसमें ये प्रिसीजन उसी टारगेटेड ट्यूमर के सेल है उन्हीं को मारा जाता है और उसके सराउंडिंग टिश्यू को डैमेज करता है.
So, sir, my next question is to you, and being a radiation oncologist, आप दिन में इतने patients देखते हैं. So, what are some of the biggest misconception that you have come across as a radiation oncologist?
So radiation के बारे में the biggest misconceptions are like the radioactivity.
अच्छा.
So patient को डर रहता है कि मुझे रेडिएशन मिल रहा है, that means I am the radioactive person. तो फैमिली में जो भी है, बच्चा है, elderly है, कोई भी रहता है, so they will get exposed because of me. So ऐसा नहीं है.
अच्छा.
रेडिएशन की वजह से आप रेडियोएक्टिव में नहीं आती. So that is the one question. Second is like रेडिएशन को बोलते हैं कि लाइट के डॉक्टर, शॉक के डॉक्टर. So we are not going to give any shock.
लाइट के डॉक्टर.
Yeah, so we are not going to give any shock or any light. We are using the photon, the X-rays, which simply we are using in our day-to-day for X-ray or CT scan. Those photons only we are using with the precision targeted area. So उसमें हम लोग जहाँ पे it is kind of local treatment. So we can divide as a oncology treatment as a systemic treatment. जो पूरा body पे act होता है, that will be taken care by the medical oncologist. And local treatment में comes role of surgery.
Achha.
And whenever the surgery is not possible, there comes role of radiation.
Achha. So that explains my first question, the multidisciplinary
Yes.
approach. So what is this with the HyperArc Radiation Therapy?
So the HyperArc is the newer technique by the Varian Linac team. So where they have introduced the some modulations with artificial intelligence, so that we can very much precisely treat the brain tumors with accuracy and without damaging the surrounding brain area.
So you said tumors. So it means we can target multiple tumors
Single
at the same
and
time?
up to the 10 to 15 tumors we can easily target.
Okay.
So with the HyperArc things in means one button go procedures,
Achha.
where you just click and the HyperArc treatment will be delivered without much interference of our technical team. Because of that, treatment will get completed within short time. Means the SRS, stereotactic radiosurgery. That means we are doing non-invasive radiation and giving effect like the surgery.
Achha.
So that previously we used to give the SRS treatment. It took around half an hour or 45 minutes, but now we can complete in 15 to 20 minutes.
Okay.
So with the higher precision, minimum treatment time, maximum sparing of normal tissues,
Okay.
so it will totally add up
Achha.
and it will give the maximum benefit to the patient.
Okay. So, sir, coming back to you, this particular line of treatment, does it have fewer side effects? What do you
Obviously,
see?
whatever targets with precision will have fewer side effects. Because radiation is a very, very focal and a local treatment, the side effects are also limited to that space where it is applied. For example, if we are giving radiation to the breast region, there will be mostly skin related side effects, which would also vanish in the next 1 month or so once the radiation is completed. For brain radiation, whatever Dr. Jagdish has already pointed out, it's a very, very ultra precise modality of treatment, targeting only that area, either the post-op area or the area of the concern, and all other adjacent neurons or cells are usually spared.
Okay.
That's the beauty of today's radiation. There are various modalities of radiation which is beyond the scope of this discussion, wherever the attempts have always been to reduce the side effect, at the same time increasing the precision on the treatment.
On the
So
treatment.
that is the crux of these things. Means nowadays oncology treatment is like targeted. We are giving the benefit, means we are expanding their life expectancy.
So basically quality of life.
Yes, along with that, quality of life nowadays it matters a lot for any patient, for any purpose.
Earlier the more was, or the modality was, more is less. Today it's less is more. They are trying to adapt to situations where ultra precise treatments only to that area, only to that organ, minimal collateral damage to others or no collateral damage to other organs, at the same time preserving all our outcomes.
So I think that
Multiple
also
outcomes.
explains about, as you said rightly, sir, that less is more.
Correct.
I think that's why the role of robotics also plays an important
Yes.
role when it comes to surgical robotics, right?
Yeah, even robotic is like also targeted therapy,
Yeah.
because see, जैसे रेडिएशन और केमोथेरेपी के साइड इफेक्ट्स को पेशेंट डरते हैं, सेम थिंग इज विद सर्जरी. सर्जरी में कैंसर सर्जरी इज वेरी म्यूटिलेटिंग सर्जरीज एंड बहुत सारी मॉर्बिडिटी रहती है. दे लूज लॉट ऑफ वर्क टाइम, हाउ टू स्टे इन द हॉस्पिटल, रिकवरी टाइम बहुत ज्यादा होता है. उसके बाद पेशेंट को बोलना नहीं आता है, फीडिंग नहीं होता है अच्छी तरह से. सो दे आर अफ्रेड कि मेरा सर्जरी होगा तो मुझे तो 4 महीना काम पे नहीं जा सकता, या फिर मुझे खाना नहीं आ सकता,
अच्छा.
मैं खा नहीं सकता, मुझे चलने को नहीं आएगा. ये सब जो डर है, अभी रोबोटिक सर्जरी में क्या होता है ना कि इंसिजन बड़ा नहीं रहता है, बहुत की होल्ड से सर्जरी की जाती है, तो उसकी वजह से ये मॉर्बिडिटी कम हो जाती है. जो उसका सर्जरी का जो वुंड रहता है वो बहुत छोटा रहता है, बहुत पिन होल से सर्जरी हो जाती है, तो ऑब्वियसली पेन विल बी लेस एंड द साइड इफेक्ट्स विल बी लेस एंड दे कैन गो होम अर्ली, दे विल बी मोबिलाइज अर्ली. सो जैसे कि रेडिएशन में सर ने बताया कि बाकी के साइड इफेक्ट्स कम होते हैं, वैसे ही रोबोटिक सर्जरी में बाकी के साइड इफेक्ट कम होते हैं एंड वी कैन सी द टारगेट बेटर.
अच्छा.
10x मैग्निफिकेशन अच्छा है, टिश्यू मैन्योर अच्छा है, ब्लीडिंग हम अच्छी तरह से कंट्रोल कर सकते हैं.
Correct.
ये सब न्यूअर मॉडलिटीज की वजह से, ये सब प्रिसीजन सॉफ्टवेयर की वजह से अभी एवरी टेक्नोलॉजी विल हैव दैट प्रिसीजन.
करेक्ट.
जैसे कि अभी सर बोल रहे थे कि रेडिएशन का जैसे प्रिसीजन पहले तो कोबाल्ट से देते थे.
अच्छा.
कोबाल्ट से क्या होता था कि एक रूम में पेशेंट को सुलाया जाता था टेबल पे, उसके बाद एक कोबाल्ट का सोर्स रखा जाता था दूसरे रूम में, और वो खिड़की खुलता था, तो उसके बाद
अच्छा.
वो पूरा पेशेंट का पूरा बॉडी कोबाल्ट को एक्सपोज होता है. तो देयर वाज नो प्रिसीजन. तो अभी क्या है ना कि ऑल दिस रेडिएशन कैसे वही टिश्यू में जाना है, एवरीथिंग इज बेस्ड ऑन दैट सॉफ्टवेयर. वो सॉफ्टवेयर डिटेक्ट करता है कि एग्जैक्टली मुझे वही टारगेट को हिट करना है. तो इसकी वजह से ये साइड इफेक्ट्स और ये सब चीजें भी कम.
That is what, when in radiation, the recent advances, what does it do? Even with targeting means hitting the target, along the side, हम लोग को ये भी कोशिश करना पड़ता है कि normal tissue को minimum radiation. So what we call that organ at risk, OAR.
अच्छा.
So
OAR.
normal tissues को भी spare करना है and target को भी hit करना है. So that comes in a sub-millimeter level.
अच्छा.
With patients के movement, body movement होते रहते हैं. ब्रीदिंग तो स्टॉप नहीं कर सकते, नॉर्मल बॉडी मूवमेंट तो रहते. सो वी हैव टू सिंक्रोनाइज ईच एंड एवरीथिंग, अकाउंट ऑल द फैक्टर्स, एंड देन वी आर डिलीवरिंग प्रिसाइजली. दैट इज व्हाट द न्यूअर टेक्नोलॉजीज आर अबाउट.
और ये बाकी का जो टिश्यू डैमेज, सराउंडिंग टिश्यू में टिश्यू डैमेज होता है, उसके जस्ट पेन वाज वन थिंग, या वो जल जाता था, ब्लैक होता था, दैट इज डिफरेंट थिंग. लेकिन उसके लॉन्ग टर्म साइड इफेक्ट भी कुछ होते थे.
अच्छा.
मतलब बाकी सराउंडिंग टिश्यू को ज्यादा रेडिएशन मिलेगा तो कुछ दिनों के बाद उसमें सार्कोमा जैसे कैंसर होने की संभावना है. तो ये सब चीजें, या फिर कार्डियक जो है, हार्ट को रेडिएशन मिलेगा तो उसके मसल का फंक्शन कम हो जाएगा, उसको कार्डियोमायोपैथी हो जाएगी. तो ये सब जो साइड इफेक्ट है, ये सिर्फ पेन और
वेरी मिनिमल.
लेकिन ये newer modalities में ये साइड इफेक्ट्स पूरे कम हो जाते हैं.
So some newer modalities में one more thing which we have heard a lot is SGRT, which is
Yes.
surface guided radiation therapy.
Yes.
So and we have heard that this particular advancement is particularly very beneficial for claustrophobic patients and for pediatric patients.
Yes.
So
yes.
how does this entire thing
So the
works?
surface guided, what previously we used to do, we used to mark 3 points coordinate over the patients.
Acha.
Either we used to do the tattoo or that. So they were the permanent marker,
Acha.
and we use them as a reference for our treatment purpose. But now with the surface guided radiotherapy, surface SGRT, what we can track, the whole surface, body surface we can track.
Okay.
So instead of only 3 markers, we have multiple millions of markers without giving tattoo. That means tattoo free.
Acha.
So we need not to poke the patients.
Okay.
Second thing, with that thing, whenever the patient is sleeping on the radiation treatment area, so he feels that some patients are claustrophobic. They feel that they are get stuck in those things. So what with surface guided, we can go with the open face treatment.
So you're saying,
open face
so you
mask.
are saying ki we can go ahead and do this without a tight mask.
Without now we have mask should be the tight.
No, I
only
mean,
the thing
the covering the entire face.
covering
Yes,
did not
yes,
to cover the entire face,
So,
eyes,
half
mouth and
of the-
everything. Yes, the
Yes.
open face mask we can
Acha.
go for the pediatric patient. Previously we used to give the short anesthesia and then we have to do the treatment. Now we can in short sedation or in just simple lie down, we can have the precision watch for them how they are getting treatment. So that is another point of the surface guided also. The radiation treatment itself it will be on 5 to 10 minutes. So during that treatment also patient can move. So we can have that watch over that also if the patient is moving during treatment or not. So we can even patient setting for the patient treatment. It takes very minimal time with the surface guided thing. These things guide us how we should move the patient so that it should be aligned. So what we have planned for the radiation. So that is the surface thing we are taking as a surrogate for the internal thing.
Acha.
And we are able to set up the patient easily. We are go with the without tattoos. We need less what we call as the less instrument to just pat the patient. It is just the simple thing. You can just go and treat the patient.
सर आपको लगता है कि this will reduce the stress that a patient has?
डेफिनेटली पहले क्या होता था ना, ऐसा पेशेंट को ऐसा पूरा पैक करके बांध के वो मशीन में डाल देते.
Mummy types.
या कि उसको पूरा मास्क करो, उसको बॉडी में टैटू करो, एंड देन टैटू करने के बाद वी हैव टू पेशेंट हैज टू वेयर द टाइट मास्क, फेस विल बी कवर्ड. तो ऑब्वियसली इफ यू आर गोइंग इन सम अननोन मशीन विथ आईज क्लोज, कवरिंग ऑन द फेस, डेफिनेटली ये डर रहता था पेशेंट में. अभी क्या है ना कि पेशेंट इज नॉट हैविंग दैट मच tight mask and tight packing. So definitely it will be psychologically better.
Even patient with open eye face, they have the sky eye view also over there. So they will not feel that.
Yeah, they can listen the music, they can see the sky. So now
Just making the
they don't
experience
feel
a
that
little better.
they have been packed and put in the machine.
Correct.
Yeah.
And newer machines also have another beauty that there's a concept of daily scans being done.
Acha.
Yes.
If the tumor starts shrinking, then your radiation gets adapted to that shrunken volume.
Yes.
Rather than the previous volume which you have planned.
Acha.
So if it's a lymphoma which is 10 centimeters, in 10 days of radiation, the lymphoma will shrink to 2 centimeters.
So it is auto
Absolutely.
adjusted.
So you would not give it now after 10 days. You would not give radiation to that 10 centimeter mask, but to the residual 2
To the
centimeter
residual
mask.
2
This is
So
centimeters.
that's the
adaptive radiotherapy.
adaptive radiotherapy, which is the beauty of the newer machines which is there.
So what
during-
is fast forward radiation?
Fast forward is the thing for the early breast cancer patient.
Acha.
We usually used to treat at least 3 or 5 to 6 weeks. महीना भर तो minimum treatment चलता था. But nowadays, what we can give, the total radiation can be finished in 5 days treatment time.
महीना भर से we have brought it down to 5
Five
days.
5 weeks to 5 days.
Yes, 5 weeks to
5
5
weeks
days.
to 5 days.
Yes, this all because of the precision and organ sparing. Like breast cancer treatment में lung और heart ये दो organs है ना,
बहुत impact होते हैं।
impact या long term, because with chemotherapy and surgical advances and with radiation, अभी breast cancer survival has increased a lot.
अच्छा।
Near normal survival है।
हाँ,
Normal.
yes.
So in that scenario, our late radiation related side effects जो heart पे होते हैं preliminary या फिर lungs पे रहते हैं, वो पहले जो issues थे now we get sorted because of the all the newer technologies in radiation. So we minimizes the heart and lung damages as much as possible. So it will be like the near normal people's. So उनको life expectancy भी normal के around मिल रही है, and then the side effects also we are minimizing.
क्या होता है ना कि अभी पहले ब्रेस्ट को रेडियोथेरेपी देना है तो ब्रेस्ट के बाजू में हार्ट है, उसके नीचे ही हार्ट है, तो बहुत ज्यादा डोज नहीं दे सकते, तो थोड़ा 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 करके ऐसा
बहुत
जो मुझे 60 ग्रे डोज देना है, लेकिन 60 ग्रे को मुझे दो ग्रे डेली देना है, क्योंकि बहुत ज्यादा डोज दिया
तो पीछे जो
हार्ट को
heart
डैमेज होगा, ये
impact
डर
जाएगा।
अभी क्या हुआ है ना कि वी आर कंप्लीटली स्पेयरिंग द हार्ट विथ इवन ब्रीदिंग भी जब होता है, ब्रेस्ट जैसा मूव होगा, रेडिएशन वो मूवमेंट के को भी मैप करेगा और सिर्फ ब्रेस्ट को ही देगा, रेडिएशन हार्ट को नहीं दिया जाता। इसीलिए अभी नाउ वी कैन गिव द बिगर डोसेस, हायर डोसेस। तो 60 ग्रे देना है लेकिन 5 दिन में दे सकते हैं, बिकॉज वी आर स्पेयरिंग द हार्ट, इसीलिए वी कैन फास्ट फॉरवर्ड दिस ट्रीटमेंट।
So, sir ने जैसा highlight किया, breathing movement is also there is the thing,
Yes,
heart treatment,
yes.
breast cancer tumor treatment,
Yes, yes.
and with breathing our organs are also moving. So there is the technique called DIBH.
Yes,
deep
actually I was
inspiration.
coming to that how DIBH helps in keeping the heart safe during the treatment.
So for left-sided breast cancer patient,
Acha.
the heart is the major concern. Okay, when we ask the patient to take the breath and hold it, so what happens? The heart get pushed away from the chest wall, our
Acha.
treatment area, and lungs will come in between these things. And even lung will be that one will be the expanded one, not the collapsed one. So what happens? The radiation to the heart is also get minimized. Radiation to the lung is also getting minimized. Along with that, we are tracking the patient, and we have set up the window in which if breathing comes in between those windows, then and then only that patient get treated. And if it shoots above or lower down that window with the breathing, so radiation will not happen. So what it ensures, हमारे टारगेट को भी रेडिएशन एक्यूरेटली मिल रहा है, एंड एट द सेम टाइम नॉर्मल टिश्यूज को हम लोग स्पेयर कर रहे हैं. सो दैट इज द व्हाट डीप इंस्पिरेशन radiation, DIBH.
So, sir, do you really think that this technique will help in reducing the number of surgeries which are required for the patients?
Number of surgeries? No, number of surgeries will not be reduced because usually in breast cancer, radiation is given after surgery.
Acha.
So all those patients जिसमें हम breast conservation surgery करते हैं.
Breast cancer, like other modalities, I mean other form of cancers.
In some of the cancers,
In some of the cancer like
Yes.
Prostate cancer, there was the initially treatment was the radical prostatectomy, but with the radiation advancements, call it as SGRT. So total radiation means tumor killing dose can be given with the radiation only. So like in rectum also, there is a surgery is the primary treatment. Though in early stage rectum cancer with chemo and radiation, the tumor responses it so much very well. Even we need not go for surgery also in that.
it's called organ preservation protocol.
Organ preservation.
Even bladder malignancies.
Bladder malignancies.
If there are few contraindications, if these contraindications are not present, the bladder preservation protocol gives combination of chemotherapy and radiation and repeated scopies to check if the disease is gone completely, and we can actually preserve these organs. So bladder, rectum, vocal cord, larynx, I would say, and prostate are organs where radical radiation plus or minus the chemotherapy would give you the same desired result as a radical surgery, avoiding the radical surgery related complications. So prostate cancer, of course, if we do a radical prostatectomy, the patients would have incontinence for a very, very long time. They could have other problems, and many of these patients would not like these problems to be quite prolonged. Radiation can take care of that. With radiation, there was always a fear that we would end up into proctitis, that is rectal inflammation, or cystitis because of involvement of very, very close proximity of both these structures. But with modern day treatment, as we said, the shrinking tumor volumes are treated with a different level of radiation. All these side effects can be either minimized or can be negated.
So, sir, before we wind up today's podcast, my last question would be to all three of you. What does the future of medical oncology, surgical oncology, or radiation oncology looks like? Because there might be a lot of people on the other side of the screen who are either recently diagnosed with cancer or might be fighting cancer for a very long time. So, what do you want to talk about the future of medical oncology? Sir, I'll start with you.
The first message that I would like to give to all is do not be afraid. Come ahead, get diagnosed and get treated. Now, once the diagnosis and treatment happens, most of the patients would live in the early stages to get cured, and all the patients who cannot get cured, that is advanced stage, would still lead a healthy and good quality life for majority of their years. Our attempt here now has been to make cancer a chronic disease, just like diabetes or blood pressure or hypertension or other diseases where you can live with the disease with some treatment ongoing. Today's era is of precision oncology, and hence chemotherapy, we are moving away from chemotherapy and more towards targeted therapy, immunotherapy, advanced molecular treatments which are available today, CAR T cell therapy for lymphomas and many other cancers, which will revolutionize the treatment of various cancers, including relapsed cancers, that is cancers which have come back. This is going to be a future of oncology or medical oncology. It's very bright, and I would say that even if the chances of getting diagnosed in the near future will be high, the chances of getting cured will be much higher. Thank you.
So, Vinod Gore, sir.
Yeah, I can say future of the oncology is Sahyadri.
Yes.
Because
That's true.
see, jokes apart, any hospital which is having the most advanced technologies in the cancer is the future of the oncology.
It's like one-stop solution.
Yeah, one-stop solution, and all the latest modalities, like we have tomotherapy in radiation, we have true beam with HyperArc in radiation, we have robot Da Vinci latest model, we have fluorescence guided techniques, we have high-tech surgeries, we have electrochemotherapies, we have targeted therapies. So all types of modalities are available, and if you treat the patient at the place where all technologies, modern technologies are available, you can treat the patient with more precision, with less side effect, and that is the future. And every patient should take advantage of these newer modalities and increase the cure rate.
So, Shejul sir, with regards to the radiation oncology, how does the future look here?
So future in total oncology, I would say oncology future is moving from the patient-centric treatment. Along with that, it is moving in more preventive way also. After getting cancer and getting treatment, it is moving that in a way that we should early diagnose the cancer, or there are some changes in our lifestyle so that we can prevent such a disease. That is what now the things are getting. And regarding the radiation thing, newer and newer techniques like variant true beam with HyperArc and tomotherapy, these are the linear advances which are delivering the high precision radiation with maximum sparing of normal tissue and helping the medical oncologists and surgical oncologists to have and to the patient to get the best of the best their result, maintaining their quality of life.
So looks like we have covered a lot of questions today when it comes to the advancements of the treatment modalities, and I once again want to thank each one of you for sparing time and being a part of this podcast. I'm very sure our viewers will have a lot of questions answered, and we will again look forward to calling all of you in the future podcast of Sahyadri Health Talks. Until then, thank you so much.
Thank you.